I'm Dr. Martin Skie. I'm one of the orthopedic hand surgeons at University of Toledo. I'd like to demonstrate a very brief exam of the hand. Okay. For the hand, a lot of it has to do with simple observation. You can look for swelling. You can look for masses like ganglia, any lesions on the skin, discoloration of the skin, or the fingernails. Okay. But quickly, let's start from the radial side. Common problems at the thumb, de Quervain's tendinitis. Simplest way to check for that is by feeling tenderness along the first extensor compartment. You can do the Finkelstein test where you have the patient grab their thumb and simply ulnar deviate to reproduce pain. Okay. The anatomic snuff box is where you're going to find scaphoid injuries, arthritis at the scaphotrapezial trapezoid joint, the STT joint. They will be tender there. Moving up, you have the base of the thumb. Very common place to get arthritis, especially in patients that are over 50 years of age. Most patients are going to have a tender spot right at the base of the thenar eminence. There's always a bone spur that forms on the volar side of the joint, right there. Okay. To examine that joint, the classic test is the grind test. You just simply take the thumb metacarpal, stabilize the wrist, axial load and rotate. People with arthritis will have reproduction of their pain, and most of the time you can feel some crepitus. The other exam is subluxation of the joint, where you grab the metacarpal and simply slide the joint out in a radial direction. Again, as that joint wears out, you'll reproduce pain by subluxing the joint. As we move up, arthritis at the MP joint of the thumb is not uncommon at all. Same thing, tenderness along the joint, and then when you load and grind the MP joint, that will reproduce their pain. On the volar side, the A1 pulley is right over the joint. Trigger thumbs are extremely common and can be reproduced with simple pressure right there. You may be able to feel the tendon, and by passively moving the interphalangeal joint, feel a nodule going back and forth under your finger if that tendon is enlarged. Okay? Passive stretching of the thumb will reproduce pain if they have a trigger thumb. IP joint arthritis, again, tenderness. You might see bone spurs. You might see a small cyst called a mucus cyst that forms at the interphalangeal joint or DIP joint of the fingers. Again, for arthritis, axial loading and a grind test is going to be the simplest exam. Back at the MP joint, if somebody has a history of an injury or you see some deformity, you need to check the collateral ligaments. The gamekeeper or skier's thumb is a rupture of the ulnar collateral ligament. They will be tender. Most often the ligament will avulse from the base of the proximal phalanx, so if it's an acute injury, there will be tenderness there. I like to check the joint, the collateral, in two positions. When you put the thumb in full extension at the MP joint, you are actually stressing the accessory collateral ligament, which attaches down on the volar plate, and then just stabilize the metacarpal and put in ulnar stress. Okay? If that's stable, you can come down and flex the MP joint about 30 degrees. That's going to isolate the proper collateral ligament, and then again, put an ulnar deviated stress on there and see if the joint opens up. Okay? So you can see if both ligaments are torn or one. Same thing on the radial side. You can test those in the same fashion. As we come to the lesser digits, the skin, you will see nodules, dimples that are consistent with Dupuytren's disease or cords or contractures. Okay? Out in the fingers, not much happens. My old partner said everything is a trigger finger, and there's some truth to that. Trigger fingers are tendinitis or a tendinopathy with tenderness right at the A1 pulley, right? The MP joint is actually back near the distal palmar crease where the fingers actually bend, not at the MP crease. So feel back in that area for tenderness. Again, if you just put your finger there and passively flex the finger, you will often feel a nodule going back and forth. So tenderness, a nodule, and then passive stretching of that tendon is going to reproduce their pain. Okay, so trigger fingers. MP joints will occasionally get arthritis. Rheumatoid patients are a different beast, but middle-aged men get osteoarthritis, often at the long and index fingers. Again, they will have tenderness along the dorsum of the joint and pain with axial load and a grind test. Okay, not much happens at the interphalangeal joints. You can test these collaterals on all these joints. On the interphalangeal joints, the collaterals are going to be stable in full extension, so pressure either way. Okay, there's a little more laxity when you flex them. MP joints are the opposite. The collaterals are going to be tight in full flexion, so if you're suspicious of a collateral ligament injury down here, flex the joint 90 degrees, and then you can see how much play there is, either with ulnar force or radial. Again, if you fully extend, the collaterals are lax, and there's quite a bit of motion in either direction. So it's difficult to tell up here as compared to down here, where it's stable. Okay? Neurologic exam, obviously sensation to light touch, or you can do two-point discrimination. The median nerve is going to give us sensation on the thumb, index, long, and half of the ring finger, so you can check that. The classic tests for carpal tunnel are going to be the Tinel's test, where you simply percuss over the course of the median nerve through the carpal tunnel region. If the patient has a palmaris longus tendon, the nerve is directly under that tendon. Okay? So Tinel's. The Phelan's test, classically, is just simply flexion of the wrist. You hold that and you should reproduce numbness in the median distribution after about 20 seconds. The last test is the Durkin compression test, where you simply apply pressure on the median nerve at the wrist. And again, you should reproduce numbness in the fingers. You'll see many hand surgeons combine those last two, where they flex the wrist and put pressure on the nerve. The only advantage is that the numbness comes very quickly when you do that. But it may not be technically the right way to do either exam. The ulnar nerve occasionally will get irritated through Guillaume's canal. You can feel the pisiform and then the hook of the hamate. The ulnar nerve is going to course through there along with the ulnar artery, so there may be a Tinel's. You can check for blood flow by doing an Allen's test. If you have the patient make a tightly clenched fist, you can occlude the radial artery and then ask them to open their fingers and make sure that they have good flow through the ulnar artery. You can repeat the same thing, occluding the ulnar artery and making sure that they have flow through the radial. I really think that's the majority of things you're going to find in your hand. Thank you.